Welcome to the Hospital Medicine Unplugged podcast. Today we're really digging into a topic that's, well, high stakes for any hospitalist. Managing Pheochromocytoma and Paraganglioma in patients who are already hospitalized. We want to go beyond just the basics and focus on the evidence-based, step-by-step approach needed for diagnosis, the critical pre-op preparation, and coordinating care for these really unstable patients.
Yeah, this is definitely a critical area. Pheochromocytoma might be rare, statistically speaking. We're talking maybe less than 2 cases per million person years, perhaps 0.05% of hypertension cases overall. But that rarity is completely overshadowed by how dangerous it can be. When these patients get sick or face surgery, the risk of sudden cardiovascular collapse or a massive hypertensive crisis is incredibly high. The evidence really shows that having a solid multidisciplinary plan makes a huge difference in outcomes, lowering both morbidity and mortality significantly. So let's break down what that plan looks like.
Okay, sounds good. Let's start at the beginning then. The pathophysiology. Why does this excess of catecholamines cause such profound instability? That's often why we see them in the hospital in the first place.
Right. It all comes down to the hormones. These are tumors of the chromatin cells, and they're just churning out massive amounts of catecholamines, mainly norepinephrine and epinephrine. But unlike the normal adrenal gland that releases them in response to stress, this tumor secretion is totally unregulated. It's often continuous, sometimes bursting in huge spikes, creating this constant hyperadrenergic state.
And you mentioned norepinephrine and epinephrine. Does it matter which one is dominant? Does that change the clinical picture?
It absolutely does. Knowing the phenotype or the dominant hormone helps us anticipate the problems. If a tumor makes mostly norepinephrine, you typically see more sustained severe hypertension. That's driven by intense alpha-adrenergic vasoconstriction, basically clamping down the blood vessels everywhere. These patients might look pale.
Okay, so norepinephrine means sustained high blood pressure. What about epinephrine?
Epinephrine is different. It hits both alpha and beta receptors. So you often get more episodic symptoms, the classic sudden spells. Think intense, sudden tachycardia, feeling incredibly anxious, shaky tremors, and just profuse sweating, that real diaphoresis. And interestingly, epinephrine's beta effects can sometimes cause vasodilation in muscle beds, leading to orthostatic hypotension, even while their baseline blood pressure is sky high. It's a bit paradoxical. Also, knowing the likely genetic link can sometimes hint at the hormone profile, like VHL syndrome tumors, often norepinephrine only.
That's a good transition. Let's talk about how these patients actually present in the hospital. It's often not that neat textbook triad of headache, palpitations, and sweating, is it? What are the acute crises we need to watch out for?
You're right. While we should know the classic triad, the hospital presentation is frequently much more dramatic, often a full-blown crisis. Top of the list is hypertensive emergency, extreme blood pressure, often with severe tachycardia. We also see dangerous arrhythmias like rapid atrial fibrillation or even VTAC. And the heart takes a real beating. The constant catecholamine flood can stun the heart muscle, leading to cardiomyopathy. This can look like Takotsubo cardiomyopathy, or sometimes a dilated form, quickly progressing to acute heart failure and pulmonary edema.
So it can present essentially like cardiogenic shock, but driven by hormones.
Exactly. A chemical assault on the heart. And it doesn't stop there. The catecholamine surge can trigger systemic inflammation, leading to multi-organ failure. We see acute kidney injury, liver dysfunction, sometimes even encephalopathy because of the wild blood pressure swings, which can mimic a stroke or even a subarachnoid hemorrhage. And though it's rare, sometimes the vasoconstriction is so severe or there's trauma that the tumor itself can rupture. That patient presents with an acute abdomen, hemorrhagic shock, a surgical emergency that hides the underlying pheo.
Wow, the systemic effects are really profound. Before we get into diagnosis, let's circle back to the genetics you mentioned. You said it's a big factor.
Huge. This is maybe one of the most important points outside of immediate management. Up to 40%, 40% of these cases are linked to inherited genetic syndromes. We're talking about conditions like multiple endocrine neoplasia type 2, MEN2, von Hippel-Lindau disease, VHL, neurofibromatosis type 1, NF1, and others.
And does knowing the specific genetic syndrome change how we approach the patient?
It can. The specific gene mutation often influences the tumor's behavior and location. For example, MEN2, caused by RET mutations, often leads to bilateral adrenal pheos, and they tend to secrete more epinephrine. They might also have medullary thyroid cancer. VHL, on the other hand, often causes single adrenal tumors that primarily make norepinephrine. Plus, VHL patients have risks like kidney cancer and brain tumors. Because of this high heritability, genetic counseling and testing are really mandatory for every single patient diagnosed. It becomes about screening the whole family, not just treating the individual. And we're also seeing more incidentalomas now, adrenal masses found on scans done for other reasons, especially in older folks, so we need to be ready to screen them biochemically too.
Okay, so we have a high clinical suspicion, maybe based on the presentation or an incidental finding. What's the very first step to actually confirm the diagnosis biochemically?
Biochemical confirmation is job one. We need to measure the breakdown products, the metabolites of catecholamines. That's because these metabolites, metanephrines and normetanephrines, are produced continuously within the tumor cells, even if the catecholamine release itself is episodic. This gives us a much more reliable diagnostic window. So the first-line tests are either plasma-free metanephrines or a 24-hour urine collection for fractionated metanephrines and normetanephrines.
In the hospital setting, is one test generally preferred over the other? Plasma seems easier logistically.
Plasma-free metanephrines can be easier, yes, and they have high sensitivity if done right. But done right is the key phrase. To get an accurate plasma level and avoid false positives from stress, the patient really needs to be fasting and lying flat, supine for at least 30 minutes before the blood draw. Getting that perfect sample in an acutely ill, maybe agitated, hospitalized patient, that can be really challenging. So sometimes, despite the hassle of collecting it, the 24-hour urine test ends up being more reliable because it averages out the secretion over a whole day.
And is there a specific level, a cutoff, that makes the diagnosis highly likely?
There is. While any elevation needs attention, if the plasma or urine metanephrines or normetanephrines are more than 3 times the upper limit of the normal range for the lab, that's highly specific for pheochromocytoma. It makes the diagnosis very probable. Levels below that 3 times threshold require more caution. We need to look closely at the clinical picture and rule out interfering factors.
Speaking of interfering factors, false positives are a known issue with these tests. What common medications should hospitalists immediately think about that could be skewing the results?
That's a huge pitfall. A lot of common drugs can interfere. Things that block catecholamine reuptake or directly affect metabolism are the main culprits. Top of the list to check for: tricyclic antidepressants like amitriptyline, MAO inhibitors, levodopa, common decongestants. Even some blood pressure meds like labetalol can mess with the assays or transiently raise metanephrines. If the patient isn't in immediate crisis, the best approach is often to stop potentially interfering meds for several days, a washout period, and then repeat the testing.
Okay, so let's say we have biochemical confirmation. Those metanephrines are clearly elevated, maybe over 3 times normal. Now we need to find the tumor. What's the imaging strategy?
Once it's biochemically confirmed, localization is next. Anatomic imaging comes first. Usually that means an adrenal-protocol CT scan or an MRI. CT is often fine for typical adrenal tumors, but MRI is generally preferred for younger patients to limit radiation, and it's definitely better for looking for extra-adrenal paragangliomas like in the abdomen, pelvis, or chest, or for bladder tumors.
And what about functional imaging? Things like MIBG scans or PT scans. When do those come into play?
Functional imaging uses tracers that are specifically taken up by the tumor cells. We reserve that for specific situations. We use it if we suspect the disease has spread, so metastatic disease, or if the CT or MRI is negative, but the biochemistry is clearly positive, meaning the tumor is hiding somewhere, or if we're dealing with recurrent disease after a previous surgery. MIBG used to be the standard, but now gallium-68 dotatate SSTR PET scanning is often considered superior, especially for tumors linked to certain genetic mutations like SDH, which have a higher risk of being malignant or metastatic.
Before we lock in on pheochromocytoma and start planning treatment, we have to consider what else could be causing these symptoms. What are the key mimics, the critical differential diagnoses we need to rule out?
The differential is broad, definitely, but we need to focus on the dangerous mimics. First are other causes of paroxysmal hypertension. Classic panic attacks can look similar symptomatically. And then there's a condition called pseudopheochromocytoma.
Can you explain pseudopheochromocytoma a bit more? How does that differ?
Yeah, pseudopheochromocytoma is tricky. It's basically a functional state where the patient has severe episodic hypertensive crises that look exactly like a pheo attack. The symptoms are identical. It's often triggered by stress or anxiety. The key difference is in the lab tests. During an episode, their actual circulating catecholamines might be high, but their metanephrines, those breakdown products we rely on for diagnosis, are usually normal or only slightly up, almost never reaching that critical 3 times normal cutoff. It's like an acute nerve-driven surge, not chronic tumor production. Beyond that, think about other emergencies. An acute aortic dissection or a subarachnoid hemorrhage can cause sudden severe headache and hypertension. Thyroid storm is another mimic high fever, tachycardia, altered mental status, but thyroid function tests will quickly sort that out. And don't forget external factors, intoxication with sympathomimetics like cocaine or amphetamines. And a classic trap is autonomic dysreflexia in patients with spinal cord injuries above T6. Something like a full bladder can trigger massive sympathetic discharge and severe hypertension.
Okay, that's a crucial list to keep in mind. Let's shift gears now to what is arguably the most critical part of hospital management, the preoperative preparation. This is where we as hospitalists play a massive role in patient safety.
Absolutely critical. There's one guiding principle here, and it's non-negotiable. Block before you cut. Any patient with a confirmed or even strongly suspected hormonally active pheochromocytoma must undergo preoperative alpha-adrenergic blockade, typically for 7 to 14 days before any surgery. This is the single most important step to prevent a cardiovascular disaster during or after the operation.
Let's talk specifics. What exactly are we trying to achieve during that 7 to 14-day prep period? What are the goals for blood pressure and other signs?
The goals are pretty well defined. We want to normalize their hemodynamics and, crucially, allow their body to replete its volume. So clinically, we're aiming for a blood pressure consistently under 130 systolic and ideally under 80 diastolic while seated. We also want to see no significant ST or T wave changes on their EKG, suggesting ongoing cardiac strain. And importantly, we actually want them to develop some orthostatic hypotension, a drop in systolic pressure of maybe 15 to 20 points when they stand up.
Yeah.
That tells us the alpha-blockade is working effectively.
Okay, so we need alpha-blockade. There are options. The non-selective drug, phenoxybenzamine, or selective alpha-1 blockers like doxazosin or terazosin is one clearly better than the other.
That's still debated, and there's no definitive winner based on current evidence for major outcomes like mortality. Phenoxybenzamine is the classic agent. It's non-competitive and irreversible, meaning it binds strongly to the alpha receptors and stays there. Some older studies suggested it might lead to slightly less severe blood pressure swings during the surgery because the blockade is so complete.
But that irreversible nature sounds like it could have downsides too.
It does. The side effects of phenoxybenzamine can be significant intense sedation, really bad nasal congestion. And because it's irreversible, patients often struggle with prolonged refractory orthostatic hypotension after the surgery, sometimes needing vasopressors for days. The selective alpha-1 blockers like doxazosin are reversible. They tend to be better tolerated pre-op and cause less persistent hypotension post-op. High-quality evidence really doesn't show a major difference in overall survival or major complications between the classes. So the choice often depends on the institution's experience and how the patient tolerates the medication.
Now let's talk about something that feels counterintuitive. Volume expansion. These patients are hypertensive, yet you're saying we need to push fluids and salt.
Yes, absolutely fundamental. Skipping this step basically guarantees problems. You have to understand the chronic state. Years, potentially, of excess norepinephrine causes intense, non-stop vasoconstriction. The kidney senses high pressure as if the body is volume overloaded. So they respond by increasing urine output pressure natriuresis and suppressing the whole renin-angiotensin system. So paradoxically, even though their blood pressure is high, these patients are actually severely volume contracted. Their vascular tank is small and constricted.
So the alpha blockade starts to relax that constricted vascular system.
Exactly. The alpha blocker opens up the pipes, increases the capacity of the vascular system. If you haven't filled that tank back up with adequate salt and fluid before surgery, the moment the surgeon removes the tumor and the catecholamine source disappears, their blood pressure will just plummet. You get refractory, life-threatening hypotension. That's why the high-salt diet and often starting IV fluids during the pre-op blockade period are absolutely mandatory. We need to refill the tank as it expands.
This leads perfectly into what might be the single most dangerous potential medication error here. The timing of beta blockers. When is it safe to add something like metoprolol or atenolol?
This is a critical teaching point. Beta blockers are used only after adequate alpha blockade is already established. Usually, that means waiting 2 to 3 days after starting the alpha blocker, and only if the patient still has significant tachycardia or troublesome arrhythmias despite the alpha blockade. The beta blocker's job here is purely to control the heart rate and rhythm, nothing else.
And what happens if we get the sequence wrong? If we start the beta blocker before the alpha blocker?
That is a recipe for disaster. a true medical emergency. If you block the beta-2 receptors first, those are the ones that cause some vasodilation, you leave the intense alpha-1 vasoconstriction completely unopposed. It's like tightening a tourniquet around the entire circulatory system. The peripheral resistance skyrockets, leading to a catastrophic hypertensive crisis, potentially causing stroke, heart attack, pulmonary edema. It's one of the biggest risk factors for a terrible outcome. Never block beta before alpha.
We also need to be aware of other drugs that can trigger a crisis, right? Beyond starting beta blockers too early, what other common hospital medications need to be strictly avoided?
Yes, vigilance is key. Anything that can cause catecholamine release or boost sympathetic tone is risky. We already mentioned tricyclic amitriptyline and MAO inhibitors. Another big one is glucocorticoids. Any systemic steroids can provoke severe, sometimes fatal, crises. Definitely avoid those if possible. Other common culprits include metoclopramide, Reglan, which can trigger catecholamine release. Certain anesthetic induction agents also need careful consideration by the anesthesia team. Basically, be cautious with anything that stimulates the sympathetic nervous system.
Okay, let's shift to managing the actual crisis. Sometimes, despite our best efforts, or maybe before the diagnosis is even made, a patient presents an acute pheochromocytoma crisis, crashing with severe hypertension, tachycardia, organ damage. What are the immediate steps for stabilization?
In a crisis, speed is everything. Immediate 4D alpha-blockade is the top priority. We need to get that blood pressure down safely and quickly. The go-to agents are typically IV phentolamine, which is a fast-acting, reversible alpha blocker given as boluses or an infusion, or continuous infusions of drugs like nitroprusside or nicardipine. Nicardipine, a calcium channel blocker, is often favored because it provides smooth, easily titratable blood pressure control and can act as a good bridge until oral alpha blockers can be started or optimized.
And how do we handle the dangerous heart rhythms or the heart failure that can happen in crisis?
Tachyarrhythmias, especially if severe, are managed with beta blockers, but again, only after alpha blockade is initiated. An ultra-short-acting agent like IV esmolol is often preferred because its effects wear off quickly if problems arise. If the patient develops severe cardiomyopathy or is in cardiogenic shock that isn't responding to medications, which can happen due to the extreme cardiotoxicity, then we need advanced support. Mechanical circulatory support, specifically VA ECMO, might be the only option to keep them alive while we get the hormonal storm under control.
We talked about the 7 to 14-day prep before surgery. What's the rule if a patient is actively in crisis in the ICU? Do we rush them to the OR?
The rule is very clear and strongly supported by evidence. Do not rush to surgery. Emergency resection during an acute, unstable crisis carries an extremely high mortality rate, potentially over 20%. The absolute priority is medical stabilization first. Get the blood pressure controlled with IV alpha blockade, manage the arrhythmias, support organ function, optimize them hemodynamically. The only exceptions would be an immediate life-threatening structural issue like the tumor actively rupturing and causing massive hemorrhage, or maybe complete refractory organ failure despite maximal medical therapy. Otherwise, stabilize first, then plan for elective surgery days later when they're stable.
Okay, stabilize first. Then surgery is the definitive treatment. What's the usual surgical approach these days? And are there special considerations for those patients with hereditary syndromes we discussed?
Right, surgery is the cure for localized disease. The preferred approach now, whenever possible, is minimally invasive surgery, either laparoscopic or retroperitonioscopic adrenalectomy. This is usually feasible for tumors under about 6 centimeters. For patients with known hereditary syndromes like MEN2, who often have bilateral adrenal tumors or a high risk of developing one in the other adrenal gland later, the situation is more complex. Removing both adrenals means lifelong steroid dependence, which has its own major morbidities. So in these cases, surgeons often attempt a cortical-sparing adrenalectomy. They try to remove the pheochromocytoma tissue, the medulla, while carefully preserving a rim of the outer adrenal cortex. The goal is to leave enough functioning cortical tissue to avoid permanent steroid dependency. It's a balance between reducing recurrence risk and preserving adrenal function.
The surgery itself sounds incredibly high risk, especially when the tumor is being handled. How does the anesthesia team manage the expected massive catecholamine surge during the operation?
It absolutely requires an anesthesiologist with specific experience in managing these cases. They need to be prepared for extreme hemodynamic swings. Rapid-acting 5E agents must be immediately available at the bedside. When the surgeon starts manipulating the tumor, especially isolating the adrenal vein, you can expect a huge dump of catecholamines into the circulation. Those intraoperative hypertensive crises are managed instantly with IV phentolamine boluses or by rapidly increasing infusions of nitroprusside or nicardipine. Then, the second the adrenal vein is clamped and ligated, the catecholamine source is cut off, and the opposite problem often occurs almost immediately.
Right, the sudden withdrawal. So that brings us to the immediate postoperative period. What are the major complications we need to anticipate right after surgery in the recovery room or ICU?
There are two big immediate dangers we have to watch for very closely: profound hypotension and significant hypoglycemia.
Let's focus on the hypertension first. Why does it happen so suddenly, and what's the management?
It's the direct result of removing the tumor and the successful preoperative alpha-blockade. The constant source of vasoconstricting catecholamines is gone. The alpha-blockade means the blood vessels are maximally dilated. And as we discussed, the patient was likely volume contracted to begin with, even with pre-op hydration. So the blood pressure just falls off a cliff. Management needs to be aggressive and anticipated. The first step is rapid, large volume YV fluid resuscitation with crystalloids. We often target higher CVP or wedge pressures than usual. If fluids alone aren't enough, we need to quickly start vasopressors, usually low-dose norepinephrine or vasopressin, to support the pressure while the body readjusts, titrating very carefully.
And the hypoglycemia, that seems less intuitive. Why does blood sugar drop after tumor removal?
It's another rebound effect, this time related to insulin. Chronically high catecholamine levels actually suppress insulin secretion from the pancreas and also promote glucose production, glycogenolysis, often making these patients relatively hyperglycemic before surgery. When the tumor is removed, that catecholamine brake on the pancreas is suddenly released. You get a surge of insulin secretion rebound hyperinsulinemia combined with now reduced glucose production. The result can be severe, rapid-onset hypoglycemia within hours. That's why frequent, strict blood glucose monitoring post-op is essential. Management usually involves giving IV dextrose, often as a continuous infusion like D10, to maintain normal blood sugar levels until the pancreas resets.
We've covered the acute phase extensively. What about the long term? What's the prognosis generally like, and why is follow-up so important even after successful surgery?
If the tumor is localized and the patient gets through the perioperative period safely with good preparation, the prognosis is generally excellent. Perioperative mortality in experienced centers is low, under 3% now. Most patients with localized disease are considered cured by the surgery. However, the picture is much less optimistic if the patient presented in crisis or if they're found to have metastatic disease.
But even for those initially cured, you mentioned a risk of recurrence. How significant is that?
It's quite significant. The risk of the disease coming back, either as a local recurrence or as new metastatic disease, is estimated between 10 and 40%. And critically, this recurrence can happen many years, even decades, after the initial surgery. The risk is higher for patients with hereditary syndromes, those who had very large tumors initially, or those whose original tumor was an extra-adrenal paraganglioma. Because of this substantial long-term risk, lifelong surveillance is generally recommended.
Can you outline the standard surveillance protocol? What tests do we do, and how often after surgery?
Surveillance typically happens in two stages. First, there's an early check, usually 2 to 8 weeks after surgery. We repeat the biochemical tests, those plasma or urine metanephrines. This confirms that the surgery was biochemically successful and helps detect any tiny residual disease. Then comes the long-term monitoring. Guidelines, like those from the NCCN, generally recommend repeating the biochemical tests every 6 to 12 months for the first few years, say the first 3 years. After that, testing might be done annually for up to 10 years, or potentially longer depending on risk factors, and definitely if any symptoms reappear. Periodic imaging, like CT or MRI of the chest, abdomen, and pelvis, is also part of surveillance, especially for those at higher risk, large tumors, genetic syndromes, paragangliomas.
And for that large group, up to 40% with a known hereditary cause.
For them, surveillance is truly lifelong and often needs to be tailored to their specific gene mutation. They remain at risk for developing new primary tumors, maybe in the other adrenal gland, or new paragangliomas elsewhere in the body. So they need regular ongoing biochemical testing and possibly imaging indefinitely based on their specific genetic risk profile.
This has been incredibly helpful, really walking through the complexities. Just to summarize the absolute key takeaways for everyone listening, high suspicion is needed. Confirmation hinges on those metanephrines being over 3 times normal. The mantra is block before you cut, meaning 7 to 14 days of alpha blockade plus aggressive volume and salt loading before surgery. Remember the critical danger.
Never start beta blockers before adequate alpha-blockade is achieved. And if faced with an acute crisis, stabilize first with IV meds like phentolamine or nicardipine, delay surgery until the patient is stable.
Exactly. And maybe one final thought to leave everyone with, thinking beyond the individual patient in the bed. When you diagnose a pheochromocytoma, especially in the hospital, remember that statistic. Up to 40% are hereditary. So that diagnosis isn't just about managing that one patient's emergency. It's a critical public health opportunity. Ensuring that patient gets comprehensive genetic counseling and testing opens the door to identifying potentially affected asymptomatic family members. Finding those relatives who carry the same mutation allows for potentially life-saving surveillance or even preventive measures for them. Your work on this one rare case could literally save lives within their entire family down the line.